We want first and foremost to feel cared for, and we want the best treatment, but the best treatment on its own without the care really isn't what any of us want.
It's reassuring that there are so many efforts in very many ways in kinship and looking at entire patient and family experiences.
I think it's a very powerful indicator of quality. I think it can be a very strong lead indicator for an organisation in a country that tells you where you're doing well and where you've got gaps emerging.
I'd say we're all fairly early on in a journey. The rhetoric has been around for a long time, but people are now starting to realise that the rhetoric hasn't actually resulted in a great deal of change, and are looking to see how they can embed system incentives into, in a sense, forcing culture change.
Many times our systems of care delivery get in the way of delivering what we call exceptional care experiences. And there are some differences certainly between the systems of healthcare delivery in the United States and the UK, but there's no doubt that they are also providing hurdles for us to deliver these exceptional care experiences.
We've got some great examples of hospitals that are doing some impressive, innovative quality improvement work to improve the patient experience, improve patient outcomes. And generally, hospitals are increasing their capacity to take on that type of basic quality improvement.
In the United States, what we've tried to do that is unique is build on the experience of the design sciences and build on our efforts in process and quality and safety, but to wrap that with the patient's and family's care experience.
I think one of the powerful things we have in Scotland is a unique ability, because of our size, to address something as a nation. We have a national quality strategy. We have 3 clear quality ambitions, one of which is person-centredness, which allows us to address the staff and patient and family component of that care experience.
It would be easy to sort of kind of feel, oh, the economic situation is going to be so challenging, we can't do anything. But actually, I think what we're hearing today is there are things that are about changing what the current workforce does and can improve patient experience.
I think there's this assumption with projects involving improvement and change that they're costly, and we found over the past year a lot of the things we're changing can have quite a high impact for patients but aren't actually that costly.
I think there's a myth that a great patient experience is going to be expensive, that patients are going to write huge long shopping lists of their wishes and wants, and actually my lived experience of listening to patients is that that's not the case. They're realistic about what the NHS can afford. Before the programme started, I think we had some of the principles of service improvement and patient involvement, but I think what the programme has done is brought it together. And definitely the element that we didn't have was it's really important to look at staff.
Before all this, a lot of our staff had a number of ideas for how they would like to make things changed to improve the patient experience, but didn't really know how to go about it. And I think a lot of it gave them the opportunity to actually listen to the patients a bit more, take the time to do that and recognise it's even more important.
I go with new learning, new contacts, and I go back energised as well.
I think it's about being able to put what we're doing into perspective of the wider NHS, and hearing from those other patient groups and hearing the sort of objective feedback that they have, and some constructive challenging of aspects of what we're doing as well.
It sends you away with challenges and ideas. I mean, I think our nurse director today has definitely picked up on the idea that she wants to get going on the Schwartz rounds, and that in our sort of service improvement portfolio is something that we really should be looking to add.
At a time when we can do more than we ever could to alleviate suffering, actually the way we're providing care at the moment often leads to avoidable harm, avoidable pain and avoidable sort of sense of hopelessness.
So much of this is zero cost. And in fact, if you get it right, you affect length of stay, you affect readmissions, you empower people to self-care and self-manage, all of which, if you're looking at the bottom line as a director of finance, are the things that are going to draw your eye.